Good afternoon, everybody. We are back with our Tuesday Multihead seminars. I'll start with a few cases, which is a mixture of surgical pathology, and then we will have a guest speaker today, our hematopathologist, Lida Bodová, who will show you some interesting heme path cases. So the first case I have is a 80-year-old lady, and she had a tumor in her abdominal wall right underneath the skin, as you can see here, a piece of surface epithelium, epidermis, and then underneath the epidermis you can see a proliferation which is very cellular, very dark blue, and very monotonous, so basically composed of very uniform small round blue cells, a little bit with salt and pepper chromatin. There were areas of necrosis. So given this overall picture, this is obviously some high-grade malignancy. Since we are looking at a case from an old person, old lady, we can create a differential based on this morphology, where I think on the first place is Merkel cell carcinoma. Of course, this morphology can be present also in some round cell sarcomas, but that would typically be found in younger patients. Typically, it's not impossible to find round cell sarcoma in an old patient, of course. So actually the second differential would be a metastasis of neuroendocrine carcinoma from other location. Theoretically, it could be some hematological malignancy, but the morphology wasn't really looking like lymphocytes or lymphoid cells. So since, as I mentioned, for me the first differential was neuroendocrine carcinoma, either primary in the skin, that means Merkel cell carcinoma, or potential metastasis. I started with cytokeratins. This is cytokeratins AE1, AE3, so broad spectrum cytokeratins, and you can see diffuse expression, which however has this funny appearance. It's a funny type of expression called perinuclear dot-like expression, which is quite typically found in Merkel cell carcinomas. Some cells also stain more diffusely, perhaps, as you can see here, but the vast majority shows this dot-like perinuclear expression. Similar expression would be found if you stain just specifically cytokeratins 20. You should see the similar type of expression, but cytokeratins 20 are included in this broad spectrum cytokeratins, so that's okay as well. So second stain you should do for neuroendocrine carcinoma of any type, besides cytokeratins, is obviously some neuroendocrine marker. So this is INSM1, which I like the best. And you can see again diffuse nuclear expression. That's why I like INSM1, because it's a nuclear marker, very easy to read. And it's relatively specific, not absolutely specific, but it's more specific than synaptophysin and more sensitive than chromogranin. So now basically we know we are most likely looking at neuroendocrine carcinoma. I've also stained CD99 to exclude Ewing. Sarcoma was completely negative. I did CD45 to kind of exclude definitely hematolymphoid neoplasm was negative. SOX10 is 100 for melanocystic or melanoma, basically in this case, was also negative. And now if we look back at the morphology, I think with this immunoprofile, cytokeratins, INSM1, we should already be focusing purely on neuroendocrine carcinomas. And now it's only about, is it primary or is it metastasis from, I don't know, pancreas or lung? So this is Merkel cell polyomavirus immunohistochemistry, which basically can highlight the Merkel cell polyomavirus infection if it's there. The staining in this case was not so fantastic as it sometimes is, not so diffuse, not so persuasive, but still you can see clearly multifocal nuclear expression, which suggests that the polyomavirus is there indeed. And just to make sure, I did molecular testing, PCR reaction for the polyomavirus, and it was positive. So this is a Merkel cell carcinoma. There are two types of Merkel cell carcinomas. The larger group is caused by Merkel cell polyomavirus. And then the second group, which is less common, it's caused by mutations in RB1, P53, and so on. So I didn't do stains for the other group because we were sure this is the Merkel cell polyomavirus group. Another stain that can be helpful for Merkel cell carcinoma is this one, SADB2. SADB2 stains a lot of things. So it's not 100% specific, but in the context of small round cell neoplasm in the skin, it can help you to diagnose this tumor. So SADB2 can be helpful. So Merkel cell carcinoma of the skin. Second case, that's very fancy soft tissue neoplasm, but it's kind of important to be, at least a little bit aware of it. It's a lesion in the tonsil of like 70-year-old male. And this is what we saw. Maybe I'm making it up. Maybe it wasn't tonsil, it was tongue. It's always tonsil or tongue in these tumors, or almost always. Doesn't matter. So one of these locations, probably tongue. And we see, again, very cellular neoplasm, but different cytology. In this case, those are, again, very monotonous cells, but they are spindled. So spindled cells. Then you have a bunch of round cells there, but those are lymphocytes or lymphoid cells, non-neoplastic admixture, which is very commonly present in these tumors and can be also considered as a helpful clue. Surface epithelium, which was normal. And as you can see, it looks everywhere the same. Quite a useful feature is its infiltrative growth. You can see the remnants of skeletal muscle here. So it invades deeply in the skeletal muscle, despite looking generally quite bland. So what we see is a kind of nondescript, very uniform spindle cell proliferation. It's very uniform, so we can already think that this could be some, fusion tumor or one single mutation type of neoplasm, and it looks mesenchymal. So since we don't know what this could be, we can do just like a basic immunohistochemical panel, which is useful for mesenchymal tumors. So again, S100, EMA, cytokeratins, desmin, as the SOX10 maybe, so the CD34, those are the markers I would start with in a case like this, and most of them were negative, apart from this one, which is desmin. You can see diffuse, strong expression in the tumor cells. You can also see that the cells actually are in the IHC look a little bit different than in the H&E. They are a little bit more elongated with this almost like a dendritic type process. And since it's desmin positive, that narrows down the differential. You can start thinking about either a smooth muscle neoplasm or skeletal muscle neoplasm. And to differentiate between that, you should do further staining. In this case, since we are in head and neck, which is very common site for rhabdomyosarcomas, and it doesn't look much like a smooth muscle neoplasm, I went straight for skeletal muscle markers, and this is MyoD1, which shows focal but clear nuclear positivity. And I already kind of hoped it will be this neoplasm, which I'll show you. It's a new subtype of rhabdomyosarcoma. It's a new subtype of rhabdomyosarcoma with VGLL3 fusions. Those are these very monotonous. I'll show you the pictures from this study by Abasagaime, basically identical to what we've seen. You can see they're always infiltratively growing, very monotonous tumors. Basically, this is like as if we took the picture from our case. So new subtype of rhabdomyosarcoma with this VGLL3 gene fusion. They seem to be very typically located in head and neck area. I don't know if I can turn it on the side somewhere. Oh, no, doesn't matter. Is the location here somewhere, or is it a different table? Oh, here, perfect. Nasopharynx, oropharynx, dorsal tongue. So always this oral cavity area. And what is most important, none of the cases so far reported, also in some other studies, none of them has ever behaved in an aggressive fashion. None of them metastasized. So despite these tumors still being called rhabdomyosarcomas, they seem to be much more indolent. And these tumors, interestingly, they are always in adults. Why is it interesting? Because there's another group of rhabdomyosarcomas, which are basically a subtype of spindle cell rhabdomyosarcomas, and they have VGLL2 fusions, not 3 but 2. And these tumors are almost always in newborns and children under 2 years of age, so it's kind of fascinating. So we have just a very similar but different gene, and one causes tumors always in adults, very indolent tumors, and the other, VGLL2, causes very or almost identical looking tumors in newborns or kids, and again, very indolent subtype. So it kind of underscores how important it is to do molecular testing in spindle cell rhabdomyosarcomas, because the other subgroups of spindle cell rhabdomyosarcomas are very, very, very aggressive.
I would just add one interesting information. When I was about to end my working in AFIP in Washington, D.C., we had a last project to do, which we never finished. It was a project of Dr. John Fetch, and he had 9 cases of tongue tumor, which he said these tumors were considered by Enzinger. He called them as fibromatosis like fibrosarcoma of tongue. He had 9 cases, I had 2 cases, but we never published it. And he said, this tumor never metastasizes. It's always, he didn't know it's rhabdomyosarcoma. He just knew that it's typical of the tongue. It's more well-differentiated sarcoma. It was even in the book of Enzinger written as fibrosarcoma-like tumor, and the tumor never metastasized. Now, Mike showed you even the genetic background and the name rhabdomyosarcoma is typical. So that not knowing it, you can make a disaster to the patient, because the patient does not need that irradiation or whatever. It's not known in pathology. It's very new thing.
And this fibrosarcoma case had a fusion also, or
This case I showed you is VGL3 fusion. It's one of the typical fusion partners. I don't remember.
So the thing always when you have mesenchymal tumor of the tongue, then it might be this tumor, and if you find out the BB, what is the name of the translocation? VGLL3, it's the non-metastasizing sarcoma of the tongue.
Yeah, basically, if you have spindle cell rhabdomyosarcoma in head and neck, always do molecular testing somewhere, even if you should send it somewhere, because it's crucial for the patient. Yeah. Okay. Next case. We are already moving a little bit in the empath area, but still also staying in mesenchymal a little bit. So this is a 45-year-old lady. She had a 13 centimeter large, but very well circumscribed tumor in the radix of her mesentery. There was a punch biopsy done somewhere else in Czech Republic, and from the punch biopsy, which kind of looked a little bit worse or a little bit more aggressive than what I will show you here, the punch biopsy diagnosis was undifferentiated pleomorphic sarcoma, or undifferentiated spindle cell sarcoma, so high grade diagnosis. And then they sent me, when the resection was done, they sent me the resection material, and this is what we saw here. So we have some lymph nodes at the edge, and then adjacent to it is the neoplasm. So when we go on higher power, you can see there's again a lot of lymphoid admixture, a lot of lymphoid cells. But in the background, there are again a little bit plump, larger spindle cells. And overall, I mean, it doesn't look benign, but it doesn't look like a undifferentiated spindle cell sarcoma. I saw the punch biopsy, they sent it to me eventually, and there was like half of the punch was necrosis. So I don't blame them calling that undifferentiated sarcoma because it was really really tough material. But from this resection, first thing I considered, anybody would have a suggestion in this location with this morphology.
So you do CD21-23 for follicular dendritic
Perfect.
cells.
Yes. That was my suggestion number 2.
Inflammatory pseudotumor something?
Yeah, that we also did in the differential, but in the radix of mesentery with this morphology, just purely by statistics, I stained MDM2 for dedifferentiated liposarcoma. You can always have so much inflammation there, and you see these sometimes quite hyperchromatic cells, hyperchromatic spindle cells in the background, which you typically see in DDIF liposarcoma. Yeah, so cells like these. So I did stain MDM2, and there was some expression actually, but definitely not enough to call this dedifferentiated liposarcoma. To make sure, I also did MDM2 FISH, and it was negative. So it's not a dedifferentiated liposarcoma. So as Natalie said, great idea to CD21, CD23, and CD35. Those are so-called follicular dendritic cell markers. They stain follicular dendritic cells and probably a bunch of other things, which I don't know. Here is the adjacent lymph node, which shows you the immuno is working well. This is CD21, but the tumor somewhere something stains, but it's not great. So I did also CD23, another follicular dendritic cell marker, again internal control, nicely positive. And in the tumor they were scattered kind of like lymphoid follicles, so I think this is the positivity there.
That's 23, right?
Yeah, 23. And we also see scattered individual cells, which are, I think, the tumor cells here. So there is some positivity, but very focal. I'm not sure if I would call follicular dendritic cell sarcoma just based on this.
Yeah.
So CD35, another follicular dendritic cell marker, and finally we have some decent positivity here. This is already pretty good. Diffuse, multifocal, or multifocal but strong, not diffuse. Yeah, and there are other markers you can use for follicular dendritic cells. CXCL13. I learned from books. I've never heard about it before, and we actually have the marker, and it seems to be pretty diffusely positive. And then there is a bunch of non-specific stains which tend to be positive in follicular dendritic cell sarcoma, like fascin, clusterin. They were also diffusely positive, but I don't put much weight on it. But anyway, these C35 and CXCL13, which is supposed to be one of the best markers for this tumor, were strongly positive in many cells. The morphology for me, at least, is perfect for follicular dendritic cell sarcoma. The presentation is very good, very sharply circumscribed, large tumor in the retroperitoneum. So I called it follicular dendritic cell sarcoma. One useful thing, even for diagnosis, but mainly for the patient, is that these tumors are typically positive with PDL1. So I also did PDL1 mainly for predictive purposes, but also kind of helped me to further establish the diagnosis. So this is PDL1. There's positivity. Actually, there is an old paper by Abbas where we contributed cases. He was the first one, I think, to discover that there are these tumors are positive for PDL1, and they show usually focal expression of MDM2. And also somatostatin receptor can be useful for these tumors as well. It was negative in this case. So follicular dendritic cell sarcoma, I think for the patient, much more hopeful diagnosis than undifferentiated spindle cell sarcoma. And my last case is here. So this is some, I think, roughly 65 years old patient who presented with quite weird clinical history. He had first he had a ischemic heart disease, and then he also complained about, or eventually was found to have multifocal arteritis. So was vasculitis basically of large vessels. And then he had some B-type symptoms, and eventually they found he has a peritoneal dissemination of some probably neoplasm. They didn't know what it is, so they did diagnostic. They excised one of the nodules on the peritoneum, and it was sent to me. And what we see here, those are just fragments from peritoneum. Perhaps here you can see, here is the peritoneal surface. So lined by mesothelium, and underneath there is some thickened layer of some cells, I don't know what, or I didn't know what, and here is the fat tissue. And it seems to be really present diffusely. In the areas where it's not damaged, the tissue is not damaged, you can see actually the cells much better. And of course there's a lot of, again, lymphoid tissue and mixed, but the predominant cells are these plump epithelioid or plasmacytoid looking cells, which are quite large, but otherwise have relatively bland features, such as this one here. And when you keep looking around, you see they are almost everywhere. It really seems to be the dominant component. And what is very interesting and useful, in some places, the cells have this stuff inside. Anybody knows what this is? Peripoiesis, exactly. So this is engulfed lymphoid cell. Basically, the large eosinophilic epithelioid cell ate or eats these little lymphocytes. And that's typical for one disease. Anybody? A suggestion? Rosai-Dorfman disease, perfect. So that was my working diagnosis before I did immunohistochemistry. Looks very similar all over the place. So what would be the stain or the stains to do?
100 CD60.
Perfect. So I just have to find stains. So it's 100. It's beautiful. It's everywhere we need it. And this 100 stain is great to confirm, or not absolutely confirm, it's not 100% specific, but it's useful to confirm the idea or the suggestion of Rosai-Dorfman. And also it helps you to highlight the emperipoiesis. The engulfed lymphocytes don't stain with S100, so you can see them very nicely. You can see even some cells have this halo around it. So very useful stain is 100 for confirming Rosai-Dorfman disease, and then definitely do also some histiocytic markers. I prefer PU1. because it's again nuclear marker. Doesn't look great in this case, but there is nuclear positivity, relatively weak, but it's there. Oh yeah, that's another slide with PU1, much better. So diffuse nuclear positivity in the epithelioid looking cells. So another important feature for Rosai-Dorfman, who doesn't like PU1, you can use CD163. It's just, I think it's much harder to read sometimes, not in this case. So diffuse positivity with histiocytic markers, diffuse positivity with S100. And you can also use another marker which is supposed to be pretty specific for Rosai-Dorfman, and that is OCT2, which should show nuclear expression.
It's the best one, yeah. This is the best one.
So OCT2, and because the patient had usually Rosai-Dorfman is a localized disease in one lymph node or few lymph nodes or in the skin, and the patients will be okay. But this guy had diffuse process. It was all over his abdomen, and that's why I also ordered molecular testing, because these tumors, or generally the histiocytic neoplasms, have very frequently targetable alterations. So this is the best paper on this topic, I think, on these histiocytic neoplasms. And they nicely say already in the introduction that many of these histiocytic neoplasms were thought to be some reactive tumors. Rosai-Dorfman disease, it's not even called a tumor, right? It's a Rosai-Dorfman disease. It was thought to be some reactive lesion, but eventually they have been shown to be clonal hematopoietic tumors, which typically have mitogen activated protein kinase MAPK signaling pathway involved. And why I'm showing this paper is because it has the best visualization of all these mutations present in these various neoplasms. So these histiocytic neoplasms, they include Erdheim-Chester disease, Langerhans cell histiocytosis, juvenile xanthogranuloma, Rosai-Dorfman disease, and histiocytic sarcoma. Those are the most well characterized and recognized histiocytic neoplasms. There are some other quite vaguely characterized, and such as interdigitating dendritic cell sarcoma. Still people argue whether that is a thing or these tumors actually don't exist. Nobody knows for sure. But these shown here, they exist. They are very well defined, and you can see the mutations that are found in them very often overlap. And when we look at the Rosai-Dorfman disease, in this case, I've shown you we had MAP2K1 pathway, MAP2K1 mutation in the MAPK pathway. So the patient can be treated with targeted therapy if necessary. So I recommend everybody to download this paper and keep it somewhere close, just because of this page. It's very easy to visualize all the mutations. Okay, so that's all from my side. Thank you for attention, and now we'll have Professor Lida Boudova here showing a few hematopathological cases.
So good afternoon, everybody. So the first case is, I hope it's focused well now. Can you see it well now? Yeah. Okay. So this is a cervical lymph node of a 55-year-old woman. She had just one enlarged lymph node on one side of her neck, and it was sent in for consultation. So at this low power, you can see increased number of follicles, and they have also increased size. The mantles are very thin, almost absent, and sometimes the follicles coalesce, creating maybe diffuse pattern. And when we want to look a little bit more closely, then in some areas you can see large cells, right? I would call these large cells you can see mitosis just in the middle, or actually there are many of them. Oh, this one. Sorry, I cannot show it, but never mind. You can see mitosis, and when we move the field a little bit more further, then you can see some cells of intermediate size, some central size, so it's a mixture. So I would have a difficulty to grade it. So apparently, we are looking at something which looks like follicular lymphoma, but the cytology is a little bit problematic, slightly. And when we go on with immunohistochemistry, then we can see the CD79A, which is a very good B cell marker, and it shows you the B cells, and it also stains plasma cells, and the stain is very nice. CD20 stains this case in a very similar way. BCL2, as expected, is positive right here. It's not massive, it's not very beautiful, but it is positive. So, okay, we are dealing with some sort of follicular lymphoma. Let's look at the Ki-67. So, sorry, I'm just looking for my mark. No, it's not here, sorry. Okay, look at this Ki-67, so it's pretty high, it's very high, I would say it's over 70%, which is quite a lot for follicular lymphoma. BCL6, which is a follicular marker, strongly positive. Similarly, CD10, which is another marker of germinal centers and follicular lymphoma, is also strongly positive. Yeah, but I decided to stain more because I was thinking I'm looking at some follicular lymphoma, but grading is a bit problematic. A lot of plasma cells and high Ki-67. So I recalled an entity which is relatively rare. So I stained for MUM1, and you know that MUM1 is used as a marker of plasma cells or post-germinal B cells in immunohistochemistry, or also stains on T cells. But here you can compare to previous stains. It stains the tumor cells very strongly, which is not normal in follicular lymphoma. So this strong staining prompts us to consider the category of, yes please. Wait, yes, it's here. So this belongs to category of large B-cell lymphoma with IRF4 rearrangement. So on this slide, you can see the whole large B-cell lymphoma family as listed in WHO and very similarly in ICC too. So this large B-cell lymphoma with IRF4 rearrangement is relatively new category. Next one, please. It was already in WHO 217, and this is a de novo mature B-cell lymphoma with follicular and or diffuse growth pattern with a strong expression of MUM1, which is IRF4, usually due to IgIRF4 gene translocations. So this entity was first described in children and young people, and this is like the majority of cases, right? In older people, like in our patient, it's rare. Typically, it affects Valder ring, cervical lymph nodes, exceptionally other sites. The disease is usually localized with no B symptoms. Yeah, and here you can see the very low frequency. The architecture, as you have seen, may be purely follicular, purely diffuse, or mixed. Yeah, so it can resemble follicular large cell lymphoma like grade 3B, which has clinical implications. Or it can look like transformation to diffuse large B-cell lymphoma, which has clinical implications too. Cytology, intermediate or large cells, which were present in our case. Mature B-cell phenotype and the strong MUM1 equals IRF4 positivity. Yeah. So we did go for the molecular tests. Could we go on the next one? Yeah. and we found IRF4 rearrangement by FISH. So this looks like some follicular lymphoma, so why should we bother with precision? Why should we bother with this new category? Well, because of the differential diagnosis I mentioned, it resembles grade 3 follicular lymphoma or diffuse large B-cell lymphoma because of the large cells and high proliferation, which could really have clinical importance. But this category, large B-cell lymphoma with IRF4 rearrangement, has a good prognosis in young people. Other problems which we might see here, these cases may be BCL2 negative, and in combination with high Ki67, this could raise concerns about follicular hyperplasia too. And I would like to show actually one, maybe the next one, and are we already there? Je to poslední už tu ten, z toho prvního. Jo, už tam není, jo, dobrý, tak jo, okay, so the nice slide actually, which you have to see because it's really, really beautiful. This is a remarkable stain for IgL lambda light chain, and here you can see just spectacular restriction, right? You can see the fully differentiated plasma cells positive for lambda, and also a little bit weaker but still strong enough expression in the large B cells, right? And on the next slide, please. This is like additional finding, but it's a beautiful thing to see. So just to sum up, this is a strange case because our patient is not young, she's older, but the localization fits its cervical lymph nodes, and actually I would like to stress this, if we see something a bit strange and not fitting, we should do more testing, like for MUM1 here. And I don't test for MUM1 in every follicular lymphoma. And as for molecular, we combined several tests here because in fragmentation analysis, we found no clonal arrangement of IgHKL, but we did confirm a clonal rearrangement unequivocal in NGS, in IgHKL, so it was very helpful. And we also needed to combine with FISH to find a break of IRF4 because NGS wasn't able to detect it. So that was the first one, and the next one is a bit shorter. And jo, začali s tou prezentací. Tou prezentací, prosím, jenom. Jo, tu pokračovat, tam je ještě další slide. Jo, okay. Okay, so the next patient is a 76-year-old woman. She had mechanical prosthesis of aortic valve, and she was on anticoagulative therapy because of it. She experienced a week of malaise, fever, high CRP. She was put on antibiotics, then experienced abdominal cramps, fell down, taken to hospital, and she was diagnosed to have splenic rupture. And the cause was clear, she had coumarin overdose. Yeah. And after 3 days of conservative therapy, splenectomy was performed. They found normal size spleen and large subcapsular hematoma. So, and what did we find? So, sorry, I will use my specs. So, what did we find? So we found a subcapsular hematoma, yeah, and a lot of blood everywhere. And then we found the white pulp here, well preserved. We found the red pulp, also well preserved. Okay, so you can also see these marginal zones around the white pulp follicles, which are normal in spleen. Yeah, so it looks like we are, well, everything done. But then let's stain a little bit when we have the possibility. So this is CD79A, yeah, the B cell marker, and you can see the follicles of the white pulp and quite a lot of cells in the red pulp, and I found them a bit worrisome because they shouldn't be here. And actually I was thinking about some low-grade B-cell lymphoma like hairy cell leukemia or marginal zone or something strange. Yeah. But we stained the panel and found the following. This is BCL2 stain, and look at the centers of the follicles, how brightly they shine. This is BCL2. Another bright picture in CD10, and this bright positivity clearly points toward the follicular lymphoma. And when we went back to cytology, okay. When we went back to cytology, then we can see really like uniform cells, which could be called centrocytes. Yeah. So this is just follicular lymphoma, grade 1, 2, and can we have next slide? Okay. Okay, and we also found the BCL2 IgH fusion by NGS, and we also found mutation STAT6, and this is all this is all well for follicular lymphoma. So the next please. Yeah, and well. Then there are some crucial additional data when we tried to get more history of the patient. This was a consultation from outside hospital. Then we found that she was diagnosed with follicular lymphoma grade 1 10 years ago, with no therapy, just on watch and wait approach. And now after splenectomy, she's fine too. So this is like tricky because the spleen, which we have just seen, shows very subtle infiltration, and I think it would be very easy to diagnose it with traumatic spleen rupture, next case. But you have just to be more careful. And on the screen there are two reproductions of just the usual appearance of follicular lymphoma in the spleen. Like you can see much more infiltration there. So that's all. Thank you very much.
Okay, here is Michael, the senior speaking. I will show you a few nice cases I had in my table in the last 2 weeks. And here is skin tumor. With proliferation of small cells, showing some mitotic activity but not conspicuous one, yeah. And one would even say it might be a benign tumor. Yeah. There is some reactive changes in eccrine glands. We did molecular genetics and we found that the tumor is KIT mutated. We further tried melanocytic markers, but they were all positive. Yeah, that was HMB45 positive, azanin protein positive, substem positive. So that it's pigmented lesions. Then we did here PRAMA staining. And you see here nice positivity, especially in nodules arising in the background of the lesion. Yeah. Yeah. It was P60 negative, and MIP1 key 67 staining is helpful as well, because you see here positivity in most of the cells, especially in the nodules. When we analyze the data we have from the case, that means especially KIT mutation, which is typical mutation for melanomas arising in sun-exposed areas. Yeah. We think it is small cell melanoma arising in the leg. Yeah. Displaying benign morphology, but you see MIB1 is so positive like it is here. If it would be low benign lesion, I mean nevus cells, you would hardly see any MIB positivity, only rare from here and there, but nothing like that. Yeah. When you add primer positivity, P60 negativity, the diagnosis is fitting to this tumor. Then I have another case. I have a tumor of the adrenals of 31-year-old female. Anyway, here you can see that there are a mixture of two things. Yeah, one that is more basophilic, and the other one that is more eosinophilic, especially in other areas. There is a third component, which is small cell sarcoma-like component, like here. Yeah? This unique component never described in this tumor elsewhere. But here you can again see this eosinophilic component. Can you see it here very nicely? Eosinophilic component, then basophilic component, and the third one, small cell sarcoma-like component. Yeah? When stain is S100 protein staining, you can just notice the two or three components here. The small cell component, which is sarcoma component, which is S100 protein negative. Then most of the component being S100 protein positive. And some smaller areas that are negative as well, yeah, like here. We did more. Cytokeratin were completely negative, all sorts of cytokeratins, A1, Oscar, CD8, CD7, CD20. And it's one of the rarest tumor of adrenals. There were described 30 cases of it only. And we have 3 cases in our file, so that I think the tumor is more frequent than considered from the small amount of published in the literature. It was just published in this in press, adrenal mixed corticomedullary tumors of adrenal glands. There is actually a tumor that have admixtured cortical adenoma at one side and pheochromocytoma on other sides, and they are grow. It permeates one into another. Yeah, of it. Is there some picture? There are not much pictures of it. That to draw. We published the case years ago, many years ago, and in our paper it was black and white, still black and white pictures. We show this small cell or this sarcoma-like component here, yeah. Then there was very nicely recognizable these areas which are cortical adenoma and the rest is pheochromocytoma. When we published it, I think it was nearly over 25 years ago. Yeah, 30 years ago. It was second case ever published, yeah. At the time it was not even recognizable whether it is entity or not. Now it is considered to be entity, and now there is described over 30 cases of this fascinating tumor. And since the time we saw two more cases, so that it definitely exists, and still it's very enigmatic. So that the question: does one component cause the growth of the other one? Are they independent? Are they interconnected somehow? And very unique is that sarcoma component inside was never described in this tumor any time in the past. Now I have another case, tumor of the 64-year-old male in scalp. And I show it because it's not rare at all. I got it in consultation with diagnosis of apocrine type adnexal hydradenocarcinoma. You see very nicely the apocrine the differentiation, the blebs that are seen on the surface of the glands, yeah. So that the confusion with apocrine type skin adnexal tumor is very great, yeah. But it's quite common, this apocrine differentiation in one type of carcinomas. Can you guess it? I showed one case in the past. When you see this architecture, you might get an idea. You should get it into your eye. It's what? No?
Prostatic adenocarcinoma.
Yes, it's metastatic prostatic adenocarcinomas. Prostatic metastatic adenocarcinomas of this architecture have nearly always apocrine-like differentiation. Yeah? So that do not confuse it with primary tumor. The patient should be treated for prostatic carcinoma. There are actually two main types. I will show you next time. The second type of metastatic prostatic adenocarcinoma is composed of very small glands, and what is specific for metastatic prostatic adenocarcinoma is mixture of this architecture with small glands. When you see the mixture of that, you must be sure that it's prostatic adenocarcinoma. Another important thing that should be known is that when prostatic adenocarcinoma metastasizes to the neck, it's always found on the left side of the neck, never on the right side. When you have on the right side, you may be sure that it's something different. The reason is ductus thoracicus. It always metastasizes through ductus thoracicus. Yeah. There was one paper, I guess they had over 50 cases, and only one was found on the right side of the neck, and 49 were found on the left side of the neck. So that it's very nice thing to remember for your future practice. I have here one tumor of the salivary glands, and I'm showing because I ask whoever present at microscope to find me and send me similar case because it's undescribed tumor of salivary glands. Yeah. Morphologically, it is very typical. It's oncocytic. And what is very typical, what is typical of it is
Wiesz tam mysi układać.
co?
Wiesz tam układa mysi.
No. Is this type of polarity. You see the glands are opened upside down. These tumors are known in kidney. In kidney they are called papillary carcinomas with reverse polarity. You see the polarity is open to the stroma. Yeah. In kidney, these tumors with papillary carcinoma reverse polarity are always KRAS mutated, and now there appeared the first major methylation profiling map of methylomas, and they found that these tumors cluster entirely different place than the rest of papillary carcinoma. That means it is a real tumor, and it is as well oncocytic like this one. Yeah. So I would like to know. I would like to have more of these cases. Here is the PAS staining, which shows the reverse polarity even better. Yeah. Look, you see the reverse polarity. So that if you would see anything like that.
But similar tumors are also in the breast, right?
Yeah, in breast as well. Yeah.
And thyroid too?
Thyroid not, no. Thyroid not, yeah. So, we call it low-grade, maybe benign tumor of salivary glands with oncocytic background and reverse polarity. It doesn't belong to any entity, yeah. It is cytokeratin 7 positive. Staining is very nicely showing it leaves out the peripheral layer and stains only inner layer. That means the peripheral layer is really something distinguished, very nicely distinguishable of the tumor. Yeah. So if you would find it, yeah, we would be interested to and if you'd like to publish it, I have no problem with that. If you'd like to take it for publication in the case report. Now here, you just got it in my table. It is tumor of the skin. It's just simple diagnosis. It can be diagnosed even from H&E slide, but you can help yourself very nicely with immunohistochemistry. The tumor was YAP1 negative, that means it was YAP1 deleted staining, and NUTM1 positive, which is typical for poromas and poroid tumors. Yeah, it doesn't say about malignancy. I think it's low grade, probably benign tumor. Yeah, I've very rarely seen malignization of these tumors. Yeah, just this immunoprofile very nicely filed to this classification. Okay, that's all. It's 3:30. See you in 1 week. Yeah. Oh, okay. The next week there is a feast in our country, so that it won't be. So that in 14 days we will meet again on this platform.